Good morning, everybody. Welcome back to the video. I say good morning. It's my morning. It may not be your morning, but it is certainly my morning. I hope everybody is doing well out there. We're going to talk about Chapter 12, Medication Administration. So we will get into that. So medications can be life-saving, but they can also be devastating. So devastating because there's thousands of people that die every year in the United States because of medication errors. So you need to always remember the 5 rights when administering medication. Indications and contraindications of a drug and aspects of the drug profile. So we're going to talk about all of these. Interpreting medication orders, advantages and disadvantages of routes of medications administration, and proper techniques and equipment. So what you must be able to do is calculate a drug dosage, select correct medication, prepare medication, and adhere to principles of safe administration. Speaking of principles of safe medication, most common type of medication errors resulting in death is giving the wrong dose of the drug. So that's going to require you to have knowledge in anatomy, physiology, patho, and pharmacology. And so that's honestly is what helped me in paramedic school years and years ago when it came to drug dosages. Is I had a hard time memorizing the drug dosage. But once I knew how the drug affected the pathophysiology of that patient, somehow the dosage just stuck with me. And so that's why it's important to understand how that drug is going to affect that patient's and how it's going to affect the patient's pathophysiology and what you're trying to accomplish with that drug that you're administering. History taking, assessment, and clinical reasoning all play a part here too. It's important to understand the patient's history. If you have a patient who presents to you with a heart rate of 48, and maybe they have a low blood pressure with that, and you're trying to kind of figure out, well, what medication can I give them to help with that blood pressure? Obviously, in the AEMT scope of practice, you wouldn't be giving medications to improve blood pressure like norepinephrine or anything like that. But as you progress, you will one day. And also, you do have a voice when you're out there. So it's important to understand the next level of care up from yourself. But what I'm getting at is that maybe the patient's taking a beta blocker. And if they're taking a beta blocker, that means that, if I do decide to give a medication to increase the blood pressure, it's going to be a drug that has beta in it. And I'm going to need to maybe give them a little more of that drug than normal. And so that is all a part of the history taking part of that. Phases of drug administration in which errors can be made include. So giving the drug order. So you're asked to administer a drug at 0.5 milligrams per kilogram an hour. And you heard 5 and maybe you missed the 0.5. And so let's say you start this patient out at 5 milligrams per kilo an hour. And so that could be a problem. Transcribing the order, right? So anytime the order is transcribed or written can be a problem. Administering the drug, the dosage and route of administration errors. Some drugs are made to be administered IV. Some drugs are made to go intramuscular, right? And so a lot of times you would make a terrible mistake if you gave a drug, let's say Epi, that's designed to be for allergic reactions. It's designed to be intramuscular, and you gave that drug IV. So that could be a big problem. And that's how medication errors occur like that. Patient monitoring. So we give the patient a medication that causes respiratory depression, and we're not monitoring that patient with end-tidal CO2 or pulse ox, and we're not paying attention to the patient's chest rise and fall. That could be a problem. Also, documentation. Medication errors occur pre-hospital and in hospital. The last thing you want is to be involved in a situation where that drug error happened in the hospital and you left yourself open because you didn't document your full treatment. So it's very important in documentation of your drug administrations. So I said the 5 rights earlier. Seems like every textbook's different. We have the 6 rights of medication administration. Extremely important: right patient, right medication, right dose, right route, right time, and the right documentation. All of these are super important. Additional medication safety considerations. Packaging. How is how is this medication packaged? But is it packaged similar to another drug that we carry? We used to carry epinephrine in a glass vial, and an ampule rather, glass ampule, that we would give to patients for allergic reactions. We carried Phenergan, and it was packaged extremely similar in a glass ampule. And if you weren't careful, you could confuse the two. And it happened actually, where a patient received Epi IV and the paramedic thought they were administering Phenergan as a nausea medication. So the labeling, same thing. How is it labeled? How are you going to store this medication? Because some medications are stored differently in different temperatures. How is it dispensed? Right, and how is it the actual administration of the drug? Medication shortages and substitutions are occurring more frequently than in the past, and that's happened a lot right now, especially. What does that mean for you? Well, that means a lot. Several drugs will come out. There was a shortage of D50, and so we put out D10 instead, right? And so that's how it is. D50. You're going to give your drug dose 50. I think was it 50 milliequivalents, but I don't know. I probably got the no. God, let me get a drink of coffee here. You're 25 grams of D50, right? And so you're going to administer that, and it's one time and done, as opposed to D10, where you're going to administer that entire bag. So like 250 milliliters. So you have to keep up with what's coming out. A lot of times there'll be drug, they may substitute a drug, another drug that's in your scope of practice, and you have to stay up on that. The packaging and concentrations may have changed since your last administration of the medication. Never assume that the box matches the vial inside. So also, we as a young paramedic, we used to give Procardia for patients with hypertensive crises. And what you would do is it was a capsule, and you would take a needle, poke a hole in the capsule, and then you would squeeze the contents of that capsule under the patient's tongue, giving it sublingual. And we had done that for a while. And one day it happened to where I had a patient who had, super hypertensive crisis, and it was prior to us having protocols, and I called and requested to give that drug, and it was denied. And I was so angry. Oh my God, I was so angry. But come to find out, they were pulling all the Procardia off the units because giving it the way we were administering it was increasing the risk of stroke. We were bringing the blood pressure down too fast, causing the increased risk in stroke. And that's when I learned right then that after, I spoke to the doctor and I was really pissed off, and he told me that, and I was a little bit embarrassed by it. And I said, then I have to do a better job as a paramedic, keeping up with what's happening and what's trending in medications. Routes of drug administration. So a route of drug administration is a way in which the drug gains access to the body. And so enteral routes, right? Enteral, you'll see it again. Access through the vascular of the gastrointestinal system. The liquids, solids, or semi-solids. Right? Then you have parenteral routes that bypasses the GI tract. And this could be a liquid, gas, or semi-solid forms of medication. And so some examples of parenteral routes: inhalation, sublingual, like I just mentioned, under the tongue, inhalation like an albuterol Atrovent treatment, sub-Q injection, an intramuscular injection, intravenous bolus, intravenous infusion, or even an intraosseous administration. Here we have a chart. We can look at the type of route, the route, and the description. So internal routes are PO or oral. The parenteral routes, sublingual. And just like I mentioned before, it could be subcutaneous or sub-Q, intramuscular or IM, or even intravenous IV. It continues, it could be inhalation. So know the differences in those two, please. Routes of drug administration: time to onset of action of parenterally administered drugs depends on the length of time it takes the medication to enter the circulation, right? Makes sense, right? Something going PO is going to take a little longer to react than something going IV. Subcutaneous route, the slowest onset, right? And there's a reason for that. Because we want that drug's got to go through all the layers of the skin before it gets to the muscle, and then it's absorbed into the circulatory system, right? So imagine how potent that drug must be that we're giving in a sub-Q or even in an IM injection. It's something to think about, because if you turn around and give that drug IV, it's designed to go through those layers of skin down to the muscle to be absorbed. That's potent. That's a potent medication. It's going to be a lot more potent than an IV medication. So you have to be careful not to confuse the two. So sub-Qs are slowest. Intramuscular drugs, liquids injected into the large skeletal muscle masses. Your IV drugs, this is going to be your next. So these are injected or infused directly into the venous system. So this could be like something that we give as like in a 10 milliliter syringe, right? Or maybe something that's mixed in IV fluids that we're going to give as an IV fluid infusion. Has a rapid onset of action, right? The good thing about when we're talking about these drugs too is the drugs going PO, the drugs going sub-Q and IM, they're much safer than the drugs that we're giving IV. Because once you give it IV, you can't get it back. Remember that. And it has a of course, IV, rapid onset of action. Your IO route, very similar to that of IV, right? This is where you're going to access the bone marrow, tubing filled with saline, rapid onset. right? Both of these are rapid onsets. Drugs for inhalation, we should know these by now, at least the ones that we're going to use the most: albuterol, Atrovent, aerosols. You can do liquids or even powders. Like there's certain steroids that are packaged as a powder that we don't use. So you can only administer drugs that you're licensed to administer, that our medical control physician, Dr. Carr, has approved. There's the standing orders, written orders, and verbal orders, all kind of we covered in EMT school. Standing orders / protocols. Then you have written orders, and then you may receive a verbal order. A lot of times, like if maybe you're calling the hospital and you're like, I've given 0.3 milligrams of epi IM. Repeated that. We're calling for a third dose. Whatever. If there's the scenario I'm trying to come up with is more of a paramedic scope of practice. Maybe I've called med control and I'm like, look, we've already administered 10 milligrams of morphine, and the patient's still in a lot of pain. We want to give some more morphine. Maybe you're discussing, maybe you have a dose in mind. Maybe you're like, how about 5 to 10 milligrams more? And the physician may come back and go, I like that. That's fine. Why don't we do 8? Right. So there's a lot of numbers going there. Right. So you need to always repeat it back. I got you, Dr. So-and-so. We're going to do 8 milligrams of morphine. We'll do it IV. And that should be good to repeat that back. Always repeat it back. How you document it, right? How you carried out the order, any complications, the patient's response to the medication. All right, so you administered 0.3 milligrams of epi sub-Q into the left shoulder or left delt, right? That's how that order was carried out without complications, and the patient responded favorably to the medications. Now the patient is no longer speaking in one-word sentences. They're speaking in 2 to 3. Their SATs are up, etc. How would you expect the healthcare provider to report the administration of a medication to you? How should you acknowledge a medication order? Well, I would expect the healthcare provider to report the administration of medication to me by saying, let's say we're running a cardiac arrest and it's time for an epi. And I'm like, okay, it's time for an epi. Let's do 1 milligram of epinephrine IV. I want them to tell me if I'm doing meds that day at the hospital. I want to hear 1 milligram of epi IV administered. Right. So I can write the time down on our sheet to keep up with that so I can chart it. Interpreting drug orders. So complete the drug order information. I think we kind of kicked this can down the street enough, but the drug name, the drug concentration, the dosage, the route, and the rate of frequency or repetition if applicable. Placing leading zeros before dosages of less than 1 unit. So I want to give 0.03 milligrams of epi. Well, that's not really good. I can. Yeah, you could use that. So yeah, we don't need that 0 in front of it. That's what they're leading at, but anyway. So yeah, I'll use the standard abbreviations that are accepted by your agency. If you don't understand a drug order, ask the doc. Hey, I need clarification on this. Drug dosages and calculations. So mathematical operations require you to convert drug orders to units in which drugs will be administered. Drug dosages are in metric units. A metric system is base minus 10 system used in science and medicine. fractions represent by place values to the right of the decimal. So let's see what they're talking about here. So we have mass grams, right? And so 1 gram is equal to 1,000 micrograms. Then we have liters. That 1 liter is 1,000 milliliters. Translating the order to units to administer basic calculations. Right, so to find the amount of drug to administer when given a physician's order and concentration of drug available, use fractions to compare information you know and information you must find out. They're talking about cross multiplying here. Let's get to the meat and potatoes. So if you're giving them, so again, I gave an example earlier, like 2 milligrams per kilogram, right? So calculate using a formula includes a drip factor, number of drops needed to infuse 1 milliliter of IV fluids. So 10 drops equals a milliliter, 15 drops. Oh yeah, so 10 drops per milliliter, 15 drops per milliliter, or 20 drops per ml. Let's look at the administration set here. We have two. We have a micro drip and a macro drip. So most of the time we don't use micro drips in pre-hospital care. Occasionally we do. Some places probably do. But most of your drug dosages can be figured on a macro drip. A micro drip is a 60 drops drip equals 1 ml. And so we don't use them that much. And we'll show you these in class too, or in lab. Check the time over which the volume is to be infused before calculating the drip. If they don't show any good examples here, we'll do it in the lab. I'm just looking to see. TKO is just to keep the vein open, right? It's going to be a certain amount of volume just to kind of go through. I'm just looking to see if they provide any better examples. Of course, before techniques of medication administration, let's talk about that. And we can come back to the drips. I don't think they're going to show any good examples. I'm probably going to have to get some stuff for you guys. So before giving any medication, perform history and assessment to determine if the medication is indicated and not contraindicated, right? So you want to make sure that they don't take any sexual enhancement drugs before you give nitro. We want to know about the medications the patient currently takes. We want to know drug allergies and the conditions that could contraindicate a particular drug. You need a complete set of vital signs. And that's the reason why I say this. Like in EMT school, I'm like, vital signs is part of your secondary survey, right? And a lot of people want to start slinging drugs before they get vital signs. And you know what? I get it. I mean, like you have a bad anaphylaxis or whatever. But at the same time, I want all the information that I can possibly have before I come up with a treatment plan, right? So I want the primary assessment done. I want the secondary assessment done. I want a set of vital signs, and then I'm going to come up with a treatment plan. You want to document the procedure when it's time to start documenting, reassess the patient and document findings, and ask the patient if they experience a change in symptoms, right? We want to know, is there a change? Is our plan working or not? Is it working? Aseptic techniques. Yep, so we're going to use an alcohol pad. We're going to wipe off wherever we're doing, whether we're sticking an IV or administering an IM medication. And there's the example of that. Got a little alcohol pad. Looks like they're fixing to give it an IM medication. Always use standard precautions. You're never going to recap a needle. You want to put that needle in the appropriate biohazard container and avoid performing any type of percutaneous procedures and moving while moving the ambulance. So if you're giving medications, it's a good idea to do that before you're going down the road or stop for a second. And that's just for IM shots, stuff like that. We're going to be giving drugs to critically ill patients, and we're not going to stop. Most of those, though, they're needleless. They go in the IV. No big deal. Oral medication. So what is the most common medication administered orally by advanced EMTs? I would have to say aspirin. Sublingual medication administration and introduce medications under the tongue. And so again, what's the most common medication sublingual by AEMTs? Yep, I would have to say nitro. Here we have the nebulized medication. We have a beta-2 agonist, the antichlorogenic liquid that are nebulized. All right, so they become a fine mist with compressed air, pressurized oxygen flowing through the liquid. The mist is inhaled in droplets in contact with the respiratory membrane. And that's what allows for that bronchial dilation. Here we have all the setup here. We have a nebulizer kit. We have some albuterol. We have a pulse ox. And we have a stethoscope. So we're going to need all of that to provide our treatment. You want to select and check the correct medication. You're going to assemble your nebulizer. And they're not going to do the mask. I prefer the mask. I don't like them holding the T connector, but whatever, right? It's all good. He's taking the albuterol. You don't necessarily have to unscrew the cap. You can put it in on top. It'll just go right in. It's because a lot of that medication sometimes will be spilled once you start screwing the cap back on, etc. See? I like to give it when it's already on. If it's already on, I just squirt the medicine through there. Put it on the correct liters per minute, 6 to 8. And so it might be 6. If you start seeing the gas vapors being produced, then hey, there you are. You're at 6. Maybe you're at 7, maybe you're at 8. But usually no more than that. We're going to tell the patient to put it in his mouth, to breathe in the medication, to breathe it out. And then we're going to reassess that patient. We've talked about MDIs in the past. I don't think we need to spend a lot of time on that. And also nitrous oxide. It's an analgesic gas. So it's a pain. It's given for pain. It's a 50-50 mix of oxygen and nitrogen. And the effects can and cause an altered mental status. The good thing about it, once you remove the nitrous oxide, usually they come back pretty quickly. So what are some of the things we're going to need for equipment for use for injections? Well, we're going to need gloves. We're going to need alcohol prep. You're going to need the proper size syringe. You're going to need the proper needles or filter straws. The filter straws is like for those glass ampules. Once you break them, for years we didn't have filter straws, but now we do. And it would filter any type of glass or anything that would be in there. Need a small gauze square and a small adhesive bandage or a Band-Aid. Need your medication vial or your medication ampule, maybe a pre-filled syringe of medication. And need to know where your sharps container is, right? Because after I do this, I'm going to need to drop that in the sharps container. Here is your syringe. This is called a plunger. This is called a barrel. And this is the shaft of the needle. That's the bevel of the needle. And this is the hilt of the needle. The hilt screws on to the needle adapter. So drawing medications from an ampule, this is that glass ampule I was talking about. There's the little line right there. That's where you need to break that off. You'll see that in lab. And so that's what they're working on. They're going to grasp the top of the ampule with a piece of gauze. You don't need to do that. You can use your hands. I think you're going to be okay. And then you're going to snap it off, taking care not to spill any of the medication or getting cut by the broken glass. Still think you're going to be okay. You're going to draw that medication up from the ampule. Draw medication from a vial. You're going to inject a volume of air equal to the volume of medication you're going to withdraw. You're going to insert the needle into the vial, inject the air into the vial, and draw the desired amount of medications into the syringe. Here we have for subcutaneous injections, I have Epi 1 to 1000. Here for anaphylaxis, fold the skin between the thumbs and the forefinger, inject into the subcutaneous tissue at about a 45-degree angle. And this is for a subcutaneous or sub-Q, right? And the max amount of volume that you can administer here is 1 milliliter, because after that it's going to be too much, and it's too much for the subcutaneous tissue to hold. And we recommend a 25 gauge needle, either 1/2 to 3/4 inches long. So you assemble, I feel like anyway, assemble your equipment, verify your medication, draw up your medication, disinfect it, grasp your skin, insert it at a 45-degree angle. After withdrawing the needle, apply a bandage to the site and reassess the patient. A lot of times sub-Q, they don't even need a Band-Aid. It usually doesn't bleed. If it is, it's a drop. See how they kind of mashed up the skin there? And look, here's the places you give sub-Q injections right here, in the abdomen, and even down here on the thighs. A lot of people get their insulin sub-Q, and they'll do it in their abdomen. A lot of times we'll give a very mild blood thinner to patients being admitted to the hospital, and it's sub-Q, the heparin sub-Q, and we'll do it. We can do it anywhere. Do it in their stomach. We can do it in their shoulder, wherever. Doesn't matter. Here's the equipment that you'll need for the procedure. That's that glass filter or filter straw. There's your needle, alcohol prep, your glass ampule, your syringe, and a Band-Aid if you need it. So you want to assemble all that equipment. You're going to verify your medication. You're going to draw up your med. Here they're going in at that 45-degree angle. See how they got the skin just kind of pinched up? It's going to bubble on the top of the skin. That's what you should see. Anyway. And then you're going to insert the needle into the skin and inject the medication. And a little Band-Aid for your trouble. And then you're going to reassess. So intramuscular injections, 2 drugs, Epi 1 to 1000 can go. We know that. What about glucagon? We got a little glucagon to help those diabetics. Again, we're going to recommend a 21 or a 23 gauge needle that's 3/4 to 1 1/2 inches long. This one's going to go 90 degrees. So not 45, it's going to go straight 90 degrees. And we're going to go the deltoid, the thighs, or the gluteus. Just right below the hip, right where it kind of meets the butt. See here, you have your preferred side. So here's your hip right there. This is kind of your butt. And you see right there, that's going to be your preferred side. Here's a vertical line that kind of goes down and kind of shows you preferred side. Shows you your hip. There's your sciatic nerve. You kind of want to stay away from that. And for your intramuscular ejection in the thigh, here's your preferred site is right here. So definitely more lateral. I'm sorry, more medial. Your deltoid muscle, this is where I like to go because it's quick, it's in the shoulder. Get it, you know, I have good access to the patient. So for your IM injections, just like your other ones, assess your equipment, verify your medication. Inject the volume of air equal to the volume of medication to be drawn up. So if I'm pulling out 2 mLs, I'm going to inject 2 mLs into the vial. Disinfect the site. Insert that needle at 90 degrees and aspirate the needle for the presence of blood. If no blood, administer the medication. So, you know, let's say I have a 3 milliliter syringe. I have 2 mLs of liquid. When I go in and I go in 90 degrees, I'm going to pull back on that plunger. And the reason why is there might be that 1% chance you're in a vein, right? So once I do that and I don't see any blood, now I'm going to push the plunger down to administer the medication. We'll withdraw the needle. A lot of times these patients do need a Band-Aid because it's deeper than sub-Q. And you can reassess the patient and document. Let's look at the equipment. So here we have our needle. We have our medication vial. We have our Band-Aid, our alcohol prep. We're going to select and verify the medication. Here we have some Benadryl, 50 milligrams per ml. We're going to inject a volume of air slightly greater than the volume of medication to be withdrawn, right? So he may be given 25 milligrams of this drug. And so if that's the case, he's going to pull back to a half a ml and push down. The air is going to go in there. And then he's going to withdraw the medication right there. You're going to clean the site. You're going to go in for the kill here, 90 degrees. See how instead of folding the skin up, now the skin is being kind of held taut. Goes all the way down to the hub. Remember, once you go in, this is where I want to pull back on that plunger to make sure I don't have blood coming in. If I have blood coming in, I'm not going to push it. I'm just going to put a Band-Aid over it and I'll shoot somewhere else over here somewhere. I've been doing it a long time and I've never, ever had one where I drew up blood. Now, I've talked to people that have, but I've never seen it. And we're going to put a Band-Aid on. Preferably a little Mickey Mouse Band-Aid to make everybody feel good about themselves. Then we're going to reassess the patient. So I don't know if we need to spend a lot of time on auto injectors. We're probably not going to. We already understand that skill. We'll play with them in lab, but I'm not going to waste your time. But we are going to talk about techniques for medication administration when it comes to IVs. So dextrose or D50 or D10, Narcan or a couple. So you're going to assemble all of your equipment. You're going to verify your medication. You're going to prepare your syringe. Clean your IV port injection. Clean your IV injection port. Attach your syringe to your injection port. Inject the medication at the proper rate. Discard that syringe in the sharps container. Flush your IV tubing. Readjust your drip rate if needed. Reassess your patient and document. So here we go. We're going to assemble all of our equipment. We have an AMP D50 here. 25 grams of D50. We have alcohol prep. We have our what I guess. Oh man. Anyway, I can't think of the name. We have our pre-filled syringe. I'll just say that for now. And you got your blood sugar over here because we're going to reevaluate that blood sugar. Verify the medication. Well, we're going to prepare the medication syringe, right? We're going to make sure we clean that IV port. Then we're going to put that D50 on. We're going to attach the syringe to the injection port, and then you're going to crimp the line. Because once we're pushing this D50 in this port, I don't want it coming back up the IV line, right? I want it to go down to the patient. So all you got to do is crimp the line so that that happens. No big deal. Pretty easy. Inject the medication at the proper rate. Some drugs, like adenosine, we're going to slam that drug quick. But in the case of most drugs, it's a slow push. Then we're going to discard the sharps into a sharps container. We're going to flush IV fluids through there. So you're going to open that bag up, let some of that drip down, and then close it back to the proper rate. Reassess the patient's blood sugar. So part of reassessment is doing just this. I'm going to ask the patient if it's, whatever drug I'm giving, whatever I'm trying to accomplish, I want to see if there's improvements. I'm going to document those improvements, but I want to compare a trending set of vitals. Hopefully, if I'm giving a respiratory drug, I'm hopefully seeing the O2 sac coming up from 90 maybe to 95, right? So I have a couple sets of vitals where maybe it starts off bad. Maybe it's 78% on room air, all right? And then I go ahead and start maybe I'm bagging the patient. Maybe I get some albuterol atrovent set up. The next set of vitals, I have the patient on oxygen, so I should see an improvement in that pulse ox. And those are good trending set of vitals that we look for. Peripheral intravenous access for patients in whom fluid administration or means for giving emergency medicine require or anticipated. Here we have an IV needle. Here's your hub. We have a Teflon catheter, the stylet, flashback chamber lets us know we're in the vein. The equipment used. Okay, so what we're going to need for an IV? Well, we're going to need gloves. We're going to need a tourniquet. We're going to need an alcohol prep. We're going to need a saline flush. We're going to need some IV a bag of IV fluids if that's what we're doing. We're going to need an IV catheter. We're going to need some gauze, some tape. We're not using antibiotic ointment, but maybe some people are. And the tincture of benzoin, it's just a real sticky, it makes it real sticky. So when you're putting your Tegaderm or something over it, you can put that down and, it'll make it super sticky. We don't carry that in the field. We should probably carry it in the hospital. And I use it sometimes there when I do EJs because I don't want that to come out. But I kind of like it. So catheter size, needles is one size smaller than the catheter. So they usually range from 24 gauge for like pediatrics all the way to a 14 gauge. 20 gauge and 18 gauge for inch and a quarter, and it's suitable for IV access in adults. I would say that's probably correct. That's all we really use in the hospital. We don't really use 16 and 14 gauges there. I wish we did at least have a 16 there, but we don't. These 16 gauges and 14 gauges are usually reserved for needle decompressions, things like that. A 22 to 24 gauge for patients of extremely small diameter or fragile veins. We find ourselves using these on peds or really hard sticks. Setting up the IV fluid and tubing. You want to check your IV fluid bag for the name. You want to check it for the expiration date. Make sure it's not damaged or leaking. You'll make sure the clarity of the fluid is what it's supposed to be. You're going to open the IV tubing package, ensure the roller clamp is turned off. You can remove the seal part from the port on the IV bag. Remove the cover from the IV tubing spike. When you write it all down, it sounds so confusing, but yet it's not. It's so easy. You insert the spike into the IV bag portion using a twisting motion. Make sure you close roller that clamp so when you squeeze your chamber, it doesn't go rolling out of your tube. You want to squeeze your drip chamber to fill it. Then you can open up your roller clamp, and you want to flush the tube and remove the air. Place the tubing where it's accessible and prepare for venipuncture. You want to select a suitable vein. And sometimes it's different. I mean, it can be all over the place. It depends on how bad you need a vein. Depends on what size vein you need. It's like on strokes. Most protocols is for at least an 18 gauge. If you show up at Rockdale with a stroke alert and you've got two 20 gauges, I appreciate it, but we're going to have to start an 18 gauge before we can do the contrast that we need to give. So, and sometimes that's a difficult task in some patients. Some patients' veins are just not that great, and so it's gonna depend on what you can get. So we have the basilic vein here, cephalic vein here. And the cephalic vein is a great vein. They used to call it the internist vein. And the reason why they said that, because even an intern could hit it. And it's pretty large. It runs right here from the thumb and runs all the way up. Here's your dorsal venous network of veins right here. They're valvy, so you gotta be careful sometimes. Little valves in the vein that helps the blood return back to the right side of the heart. Makes it more narrow so that the blood coming through can come through a more narrow spot, increases the PSI of the blood. But unfortunately, it's not good for IVs. Venipuncture. So that you want to make sure you disinfect the site. You're going to hold that IV catheter around a 45-degree angle with the bevel up. You're going to line it up for the direction of the needle with the direction of the vein and puncture. Once you see blood that's visible in the chamber, you can lower your angle of the needle to almost flush with the skin. And then you want to advance it about another millimeter or two. And then push the catheter over the needle till the hub is in contact with the skin. Never pull the catheter back over the needle, even though people do it, Probably not. It's not good, because if a piece of that plastic breaks off, then you got somebody, then you got a, potential PE. So that's the reason why you don't want to do that. You want to release the tourniquet and apply pressure to the end of the catheter with a finger, keeping a finger on the vein to occlude it, connect the IV tubing to the catheter, and just flow rate. So the only thing I would recommend on this is always pop your tourniquet before you decide to open your drip chamber or before you give your IV flush, because sometimes leaving the tourniquet on and forgetting to take it off can cause the vein to blow. So if you had a really hard stick and you've done really good to get the IV and you forgot to take the tourniquet off and now your vein's blown, you feel kind of bad about that. Here's all your equipment. So we have a INT or J-hub. You have your Tegaderm. This is the drip set that's going to plug in right here. So that cap pops off. The pointed part of the drip set is going to plug in there. You have your Tegaderm, alcohol prep, 20 gauge catheter, and a tourniquet. Check the fluid, inspect the clarity, make sure it's not expired. Here's that part I was talking about. See, that's that pointed part of the jip chamber, right? And we're going to spike that IV tubing through there. Open your roller clamp. This is going to allow you to flush that IV. Put that tourniquet on better than that. Make it super tight. So, yeah, I get it. It's probably just for the picture, but that's not a tight tourniquet. Here they're looking for an AC, something like that in this area, and a cubicle vein maybe. They're large. They're usually easy to hit. Here you got them. Let me see. Let me go back real quick. Oh. All right, so here you have them. So they've got blood in that drip chamber. I'm sorry, in the chamber here. Now it's time to come down more. They can come down more now and advance that catheter in. And that's just what they do. They're going to pop the tourniquet off. And see how they're going to come up. Sorry. They're going to come above the vein and they're going to apply pressure there. They're going to apply pressure there. That will mash the vein down so that when you pop this off, blood doesn't come out and go everywhere. After that, you can open your drip chamber here and you can give it a little flush and make sure that it's good. Put your Tegaderm over that. So what do you do for unsuccessful IV attempts and discontinuing IV therapy? An unsuccessful attempt may occur because the vein moves away from the needle. Rolling veins. Needle punctures both sides of a vein. That happens. Catheter meets resistance from a valve. That valve I was telling you about. Or the angle of the insertion is just wrong. A lot of times though, sometimes you can have a vein that blows at the beginning, but you can advance the catheter past the part that blows. And so if that's the case and you still have a good IV, you just have a little bit of swelling around the insertion site. That happens sometimes too. So you want to discontinue your IV therapy, turn your IV fluids off, remove the IV needle, put a Band-Aid over it or some gauze. If you're changing an IV bag, change it when you have a few millimeters of fluid left in the bag. That way you don't have to reflush the line. Close the roller clamp, pull the bag off the spike, and respike the second bag. So what are the complications? Well, I will tell you, infection is a big complication. We see it inside the hospital, believe it or not. Patients returning back to the ER after being admitted to the hospital, and now they have a little bit of cellulitis. So that infection is a problem. That's the reason why it is important to make sure that we are, cleaning that site with alcohol. Infiltration. This is where the fluid flows underneath the skin. And air or catheter embolism, a lot more rare. Bruising or hematoma, a thrombosis, pretty rare. Phlebitis, not so rare. A pyrogenic reaction, rare. And fluid overload, not completely rare. Heart failure patients, elderly, and pediatric patients are at risk of fluid overload. Remember that. You'll see it again. Heart failure patients, elderly, and peds. You want to calculate your infusion rate accurately, Monitor rates of IV infusion carefully. Check for signs of fluid overload. Here we have the pediatric intraosseous. We'll cover this in lab. Adjustable plastic disc, your cannula, your trocar needle handle. We'll talk about the contraindications, a fracture of the extremity, a previous IO attempt in the same bone, osteogenesis imperfecta, where the bone's deformed from some type of genetic reason, osteoporosis, or infection over the insertion site. Complications of IO attempts, incorrect placement, obstruction of needle, fracture, infection, compartmental syndrome, and a fat emboli. Here's all the equipment you'll need. We'll cover it in lab. All right, you want to find the proper site. Make sure you got the correct needle. Clean it. Put it on your IO gun. Drill it. We're going to cover it in lab, so don't worry. You're going to retract your needle. You want to observe for free flow fluid, absence of infiltration to the tissue. Hook up your IV bag to it. Tag them if you need to. We never do that. That's it. All right. We'll cover the IO in lab. We'll cover every bit of this in lab. All right. Hope you enjoyed it. We'll get back with some medication formulas on how to do that. Okay. That'll be coming up. Talk to you on the next video.